Good afternoon, doctors. And now we begin the symposium, which is titled, I think, Syntegrated Management of both Neovascular ARMD and Diabetic Macular Edema Beyond VEGF Inhibition. And for that, we have with us Dr. Ajay Dudani, who will make a presentation, after which Dr. Lalit Verma, who currently is busy with another symposium running in another hall, he'll come here in about 15 minutes. So after Dr. Ajay Dudani finishes his presentation, then Dr. Lalit Verma will moderate a session with the panelists, Dr. Mahesh and Dr. Raja Narayanan. And then, of course, we can have questions from the audience as well as the questions that Dr. Lalit Verma will ask the panelists. My name is Dr. Viraj Suvarna, and I work as the Chief Medical Officer for Roche Pharma, India. So without further ado, may I invite Dr. Ajay Dudani to take us through his presentation.
Thank you. Can I please have my slides? Yeah, thank you. So I really want to thank the audience who have, I think, skipped their lunch or delayed their lunch and been kind enough to attend this session. And I will try not to disappoint you all in my presentation. So we have this title which we have given to the topic called as Syntegrated Management of Neovascular AMD and DME Beyond VEGF Inhibition. So Syntegrated is a synergistic integration which we are looking at. So I will tell you all how it comes about in this case. So we are all aware that neovascular AMD and DME remain the leading cause of vision loss with increasing global prevalence, and India being having the highest number of population in the world. So we're going to see more and more patients. We have more than 2 million people globally with neovascular AMD and 18 million people with DME, and it's supposed to projected to increase more than 50% by 2024. So we're going to have a big problem at our hands. Anti-VEGF therapies have redefined the care of patients with retinal diseases. And since last 20 years, we've been using these injections. I still remember the days when we started with Macugen. Sir also would remember. Then we moved to ranibizumab, aflibercept, and brolucizumab. And since this is a Roche symposium, we should not forget to mention Avastin, which has been like, a lifesaver for a country like this, in saving so many precious sites of people who couldn't afford these expensive therapies. So anti-VEGFs require frequent injections to achieve optimal visual outcome. However, this is not feasible in the real world settings. Trials apart and real world, I think, are totally two diametrically opposite situations where the real world situation doesn't reflect the trials, because the trials have such stringent, criteria and multiple injections, which the results don't reflect back in real life, what we have seen. So we have seen that the sad part is that both these diseases require sustained and effective treatments to optimize patient outcomes. So the patient and the caregiver have a burden which creates a barrier to the treatment, can result in undertreatment, which is the bugbear of these diseases. The treatment burden, which contributes to suboptimal long-term visual outcome in these patients, because there's so many injections we have to give to so many patients repeatedly. And anti-VEGFs do not completely address the multifactorial nature of the disease, which includes an inflammatory component. So this was very beautifully brought out by the use of steroids in patients with DME, but we didn't have such, synergistic therapy for wet AMD. So anti-VEGF therapies have redefined the care of patients with retinal disorders. We have now become an injection-based sort of, specialty, especially vitreoretina. The novel therapies and mechanism of action targeting additional pathways may provide increased durability. And so here we are coming to this twin thing that we are looking at, neutralizing of both ANG2 and VEGF-A. These are two distinct pathways involved in neovascular AMD and DME, and may lead to more sustained visual stabilization over a single anti-VEGF-A alone. So we have this new drug which was launched in 2022, faricimab. It's a bispecific antibody which is targeting both ANG2 and VEGF-A. So we have a synergistic drug here which is working on two neurotransmitters, you could say, or and so the evidence for the role of ANG2 and VEGF-A dual inhibition in both these diseases. So ANG1 and ANG2 are two cousins, you could say. The ANG1 which is available, ensures the vascular stability, and it's in high concentration in healthy tissues. It activates the Tie2 receptors. However, ANG2 is upregulated in ischemic conditions of retinal vascular diseases, and ANG2 and VEGF are upregulated in the vitreous of patients with any vascular diseases, including vein occlusions. And ANG2 competes with ANG1 for the Tie2 receptors. Just tolerate me this for these words. I'll make it easier in the cartoon which comes later. And both these ANG2 and VEGF have a synergistic effect in causing leakage and inflammation and leading to vascular instability. So dual inhibition may synergistically promote vascular stability and reduce leakage, which is what we are looking out in these patients. So what is this ANG2 and VEGF pathways in healthy tissue? If you see this cartoon here, this is showing you that ANG1 is normally going to get attached to the Tie2 receptors, which are there in most of the cells in the, it's a tyrosine kinase receptor which is there on everybody's cell, especially in the vascular cells of the retina and the vitreous, the endothelial cells, and the VEGF-A is here expressed to the VEGFR2 receptors here. So this maintains the stability of the vascular stability. It prevents the vascular leakage. The endothelial cell to pericyte cell ratio is maintained well due to this system of ANG1 and Tie2 receptors, with the Tie2 activation maintaining the tight vascular junctions and the desmosomes here. So what happens when you have an increased expression of ANG2, which is along with VEGF is secreted as a part of ischemia or hypoxia in the tissue. So here what happens, the ANG2, as you can see, is displacing ANG1 here. And following this angiogenic switch, there's activated levels of ANG2, which now goes and blocks this Tie2 receptors here. So the stability of the vascular cells is affected. Along with that, here VEGF-A is increased, and it's causing the stimulation of the VEGFR receptors, which promotes angiogenesis and formation of new sprouts of new vessels. So there is basically vascular instability and neovascularization which is happening. So in conditions of stress, there is an angiogenic switch which comes on. There's an ANG2 upregulation and a VEGF upregulation, which leads to vascular leakage, neovascularization, and inflammation, which is the signs of all vascular diseases which we see in the retina. So this balance has to be recovered in patients who are having this disease. And you can see that the ANG2 is the devil here, and here's the god of ANG1, which we want. So you want a resting stability state. So you want to reverse this graph back to normal. So ANG2 levels are upregulated in the various retinal vascular diseases, and the Tie2 pathway is the driving force of the vascular instability which we see in all the pathological conditions. So here you can see that all these diseases, the level of ANG2 is high. So we have vitreous high levels of ANG2, which prove that there is a basically pathological mechanism through which this inflammation is acting. So this cartoon, I think, shows you very beautifully how this whole procedure is working, how ANG2 is leading to, breakdown in the endothelial tight junctions, which we call as desmosomes, which will, cause leakage of inflammatory leukocytes and, inflammatory materials outside. The pericyte cells drop out. With VEGF around, there's vascular sprouting with the tip of the new vascular sprouts causing the further growth of these vessels. These vessels obviously are immature because they don't have associated pericytes surrounding them, so they start to bleed and leak and cause complications of PDR, which we see. So let's get back to the drug which we are talking about now, which is this new molecule on the block. It's called Vabysmo, which is faricimab. It's a single molecule that stabilizes the blood vessels by targeting both ANG2 and VEGF-A, the two key drivers of retinal and choroidal vascular diseases. So it's a very unique molecule, as you can see in this diagram. It's a bispecific antibody which binds both to these ANG2 and VEGF-A simultaneously, as you can see here. And this is the FC region which reduces the systemic exposure and the inflammatory potential of this drug. So now we are worried about these drugs causing inflammation, as you're aware of one of the competitor drugs which causes intravitreal inflammation in these eyes. So when you bind this ANG2, it allows the ANG1, which is the good person, to reoccupy the Tie2 receptors and promotes vascular stability and suppresses inflammation. And when you bind the VEGF-A, it prevents neovascularization. So you've got very happy retina, which is coming back to its normal stage. So this combined neutralization with faricimab has a more sustained stabilization of vessels as opposed to a single VEGF-A inhibition alone. So I was there in AO just last year, and the real life data, what my colleagues, I discussed with them that the patient actually appreciates a better visual outcome post injection very rapidly in this. So I think this twin inhibition is quite effective in producing clinical results which we see in real life data also. So there were these two trials. I'll bore you a little bit, just tolerate me a little bit for these busy slides. So we had these, most of these drugs to get FDA approval, they require twin trials. So for DME, they had a yosemite and a Rhine trial. And for neovascular AMD, they had a Tenaya Lucerne trial. Okay, so this was basically for 1 year, which was extended further beyond to 2 years. So this is the phase 3 2-year data I'll tell you for neovascular AMD. So here I just want to show you all the important points here, that you initially have a 4 loading dose, and then you have a primary endpoint at 1 year, and then the extended endpoint when you have the treat and extend, depending on what the personalized treatment interval is, what they've called here, So you can decide, personalize the treatment for each patient and make it a PRN, and reduce the number of injections. And this is the improvement. So this was a non-inferiority trial which proved non-inferiority to aflibercept, which was the molecule which we were testing it with, So here you can see the visual gains from baseline with faricimab up to Q16 weeks when non-inferior to aflibercept, Q8 weeks. So means, 16 weeks is what you could extend your treatment interval between 2 injections here, as you can see. So these graphs are coming so close to each other. And this is second phase, where the second year they let you, plan the treatment on PRN basis as and when personalized treatment when the patient needs the injections. So you can see here the mean number of injections during the entire study were much less compared to aflibercept, like 15 versus 10, because you're using it every 4 monthly. And in the second year here, as you can see, that the injections are half of aflibercept is what is showing in this trial. And we always look at the OCT. We want to see that flattening of the macular fluid collection, the central subfoveal thickness reduced very well in both the subgroups. You can see almost 130 microns was the reduction. So again, here you can see the median number of injections is almost half in the second year. And the greater anatomical improvement in patients with faricimab versus aflibercept during the matched dosing period through week 12. So this is what maybe gives a better vision, the boost to the vision which the patient is experiencing in real life also. So more patients treated with faricimab achieved first the absence of IRF and SRF faster with fewer injections versus, yeah, sir, please. So we have Dr. Lalit who's going to join us. So in the post hoc analysis, also there is a very rapid improvement in the SRF and the IRF, which is the main two areas where the fluid is there, which causes vision loss. So here you can see that, by 2 years, more than 60% of the faricimab treatment patients achieved a Q16 week dosing. So we are reducing the number of injections in these patients, which is very important, to almost every 4 monthly if you're getting every injection, and 80% achieved a Q12, So it's like, as it progresses, the need for multiple injections is reducing and the interval between 2 treatments can be extended. Now, as we are very worried about, how is the toleration of this drug? So retinal vasculitis events are almost 0. The intraocular inflammation events are there, which is comparable to the competitor, but the vasculitis and the occlusive retinal vasculitis is 0 in this patient. So it's a very safe drug. So this is just the take home last slide. If you have been sleeping, you can just see this slide and, get the take home message. So over 2 years, faricimab demonstrates durable efficacy and rapid anatomical improvements with fewer injections in neovascular AMD. There's an improved and a rapid disease control. Most patients achieved absence of retinal fluid faster than with aflibercept, and comparable CST reductions with fewer injections. So comparable vision gains with fewer injections, and it's well tolerated and has a good safety profile is what we always worried about in all our patients. You don't want a new disease in a patient who's already suffering so much. So I'll again indulge you, ask for your indulgence for my some more busy slides about DME. This is the Yosemite and the Rhine study which was done. So here, as you can see, that initially there are three subsets in this. So you have faricimab Q8, and faricimab you can give personalized treatment from beginning itself. You are doing after 4 loading doses, as you can see here. And then you have the primary endpoint and the study endpoint, which is at 1 year and 2 years. Yeah. So you can see again here, even the personalized treatment option where the surgeon can decide how often he wants to give the injections is matching very well with the, Q8, Q4 or Q8 intervals, as you can see here. That's the green graph if you see, So you can reduce the number of injections very well and have the same endpoint results in these patients. So visual gains with faricimab are comparable with fewer injections. That is the main caveat which I want to share with you all. So you can see here the number of injections, 14, and here, depending on personalized treatment, you can reduce it to almost 11 injections here, because the patient has that much of, effectivity in these patients. So the reduction in CST with faricimab exceeded aflibercept at 1 year and were maintained through 2 years. So the durability also of this drug is quite proven here with a fewer number of injections, as we said. So more patients treated with the faricimab Q8 and up to Q16 achieved the absence of DME faster with fewer injections. And most patients treated with faricimab achieved absence of intraretinal fluid faster and with fewer injections. So again here, as you can see, that more faricimab patients had reduction of macular leakage. So here again, the proportion of patients I want to tell you all who received Q16 and almost Q12 dosing, they increased from 1 year to the second year. So you can see here that the number of patients, as we are aware of diabetes, the need for injection in the first year is the highest, and in the second year and also the third year, the number of injections tend to keep on reducing as we proceed ahead. And again, as we are worried about retinal vasculitis, inflammation was as much as the other competitor drugs which were used, but the vascular events of occlusions were not seen. So this again proves the safety of the drug. This is the take-home summary slide again for diabetes. So over 2 years, faricimab demonstrated durable efficacy, superior anatomical outcomes with fewer injections. And the change in CST was more favorable for the faricimab group. Numerically, more patients achieved absence of DME and absence of IRF. And there was greater fluid control with up to almost 16-week dosing. That's like, very nice. I think 4 monthly, if you have to give injections to patients, the patient's also happy and you're also happy. So comparable vision gains with fewer injections, and it's well tolerated with a good safety profile, as I said. So dual inhibition has the potential to optimize the missing link, which you could say, which is there in these two diseases. And it's a multifactorial disease, so it requires a multi-pronged effect, here you could say. So we are treating two pathways simultaneously, the ANG2 and the TIE2 pathway, and of course the VEGF pathway, which is there. So the recent phase 3 data show that the dual pathway leads to a greater durability and prolonged disease control with prolonged vascular stability. So just one case I want to share with you all, in each of these subsets which I had. So this is a 75-year-old diabetic male who had diabetes for 26 years. He was obviously poorly controlled, and he came with a diffuse diabetic macular edema with moderate NPDR. So we decided to start him with Ozurdex, and then we did a little scatter laser for his peripheral diabetic retinopathy, which was quite severe, NPDR. Then we switched to Paginex because you'll see why. So this is how we came with the right and the left eye. You can see that there is subretinal fluid with cystic fluid here, diabetic macular edema. So post Ozurdex, the right eye somehow didn't respond. The left eye looked better. So this gentleman was going out of town, and he was reaching the end of his 3 months of the first therapy. So we said that since he's not responded so well to it, so we switched him to Paginex in his both the eyes. The left eye did very beautifully, and the right eye still, you can see, is having this fluid here. So maybe this could be one of the patients which fills in the gap which is missing and using this newer molecule, Vabysmo. But I'm open to correction from the audience and the stalwarts on the stage, so we can have a discussion on that. This is my second patient of a CNVM who I've been treating since 2017. He's a 79-year-old male who's very, like, educated, erudite, and he knows his disease more than me, I think. So we started this story in 2017. He was 6'12". We started with ranibizumab monthly, then PRN. He said, just do the treatment, doctor, you want to do. And he's the most, reliable patient who will come for follow-ups one day before, but not one day late. So this is how the story, I'll just show you all with the active thing. So 2017, this is how the story starts with, submacular fluid which came up. He responded well to, intravitreal eccentrics. Then he came up with this PED, and then we realized that this is an IPCV with a double laminar sign. And then he came with a bleed, so we gave intravitreal eccentrics with gas to shift that blood. Then again he came with another bleed. Then again we repeated the same things. Then, during COVID time, he was admitted in ICU, and then he told me, come and give me an injection there itself. He was that sincere. But then he came post-COVID after he was released, and this is how the picture was. And then we decided to switch him on brolucizumab. And again, he responded, that SHREM, which you can see. And there was a flattening observed, So you would wonder that why am I treating this patient? Because the other eye has soft drusen, and this eye, the patient was maintaining a vision of 660. And he's insisting on treating himself. So he improved, Even I was surprised that in spite of that bad a retina, he had a, foveal contour here, partly came back, and the scar moved to the periphery. But he keeps recurring, and he has received almost 10 brolucizumabs, and this is how he's looking like, after 10. So there is still some recurrence which is there. So as we know that this AMD disease doesn't go away. So maybe this could help us, this is a drug. I'm just sharing with you all. I'm open to, yeah. So thank you very much for your indulging me and your patient hearing. Thank you.
Dudani, I'm slightly confused. You switched to webinars, or you may switch to
No, may. I was said. These are the patients I'm saying that. Sorry, I have not written that. Yeah.
Yeah.
Means switch to.
Because what Raja and me were saying, Vabysmo, aaya to nahi hai. Where have you got it from?
No, sorry. So I'm just discussing. These are the two patients you may switch to Vabysmo.
So you are collecting patients for Vabysmo.
Yeah. So I stand corrected. Yes, I stand.
No, you are collecting patients for that.
It will take time though. You still have to treat them with something before Vabysmo comes. Yeah. So, is there?
Thank you.
Thank you. Very nice presentation. I think what it shows is this is a bispecific antibody. First time that one antibody is targeting two different molecules, VEGF and angiotensin, or angiopoietin 2 actually. And the more important effect that people are looking forward to is the durability, that is less frequent injection. That is the most important differentiator for this molecule faricimab compared to the other commonly used anti-VEGF. And we saw that the visual acuity gains, obviously they were non-inferior compared to aflibercept. But it leads to a lot of questions in how to involve patients in the decision making in terms of when it comes to the PTI. So if I can ask Dr. Dudani about the personalized treatment interval, especially for AMD and DME, there were some differences in the way the injection protocol was there in terms of PTI. So let's look at DME patients. What is the critical time point after the initial monthly injections? Will you start looking whether to start giving a PTI, which is treat and extend for DME, or you will use a Q8-week protocol? How will you decide that?
I think I've seen that in there's a basic difference between DME and AMD fluid. DME fluid is more forgiving, so you don't have to run after all fluid is what I feel in DME. And I would rather follow a patient on vision in a DME versus fluid, unless the fluid is overwhelmingly too much in the IRF, is what I feel. Intraretinal fluid is too much. But I think in vis-a-vis versus in neovascular AMD, I think any fluid needs to be run after, because that can lead to prolonged vision loss. So in this, because diabetes being a multifactorial disease, I think controlling the systemic condition, controlling his anemia, controlling his metabolic profile, along with injections is what I would follow, in that. So I think I would not only go by
Dhani,
OCT.
in one of the arms, whatever I could understand, aflibercept was not allowed for Q12, was allowed at only Q8 in the initial, whereas this molecule was allowed. So are these comparable, or?
Means actually that was the study design was that way, for the DME they had a third arm, as I told you, which you could plan as per PRN from beginning after loading dose. So one difference what I found is that aflibercept has giving 3 loading doses, whereas in most of the Vabysmo study there are 4 loading doses. That was the criteria. I saw all the things, if you have seen that.
No, all of us, it looks very attractive.
Yeah.
Frankly speaking, I wanted somebody to tell us, has the countries where it is now available, have they shifted, and are they experiencing wow effect?
So that's what I was lucky enough to be for the American Academy last year, and I was there in 1 or 2 discussions with my colleagues in the American Subspecialty Day for Retina, and most of them have moved to this drug because the patient is having a very wow effect. Like I spoke
You
to
see, what we
Prithvi,
saw was that in whatever I know, in US and other places, the usage of ranibizumab has dropped. Aflibercept is number
Very
one.
true,
Aflibercept is number one. Whereas, has this, after this, yosemite, Rhine and these studies, has the usage of aflibercept gone down, and this has picked up like this?
that I'm not very aware of, but they are more and more switching to that because there were very many talks on this drug. That's what I
Yeah, and what little bit I know of, sir, is already 1 million plus doses have been used of Vabysmo in just about little more than a year. So clearly it is affecting, I mean, people are switching from aflibercept to faricimab, but more of it, like if you see the real world publications, recently Truckee got published just today by Dr. Khanani. And that's an independent study, nothing to do with Roche. And there also what he's looked at, 396 patients only. And there the naive patients did better, than the ones who switched. But both were there.
So if you are looking at wow effect in terms of OCT reduction, I would say both are very similar. Aflibercept and faricimab, compared to, let's say, brolucizumab in AMD, had a very, very wow effect compared to aflibercept. But here the fluid reduction more or less similar, and if you see the overall OCT reduction, you see a sawtooth appearance very nicely for aflibercept Q8 itself. Whereas for the faricimab PTI, it was more like a flat line, that the patient is not having too much of variation in the edema. But what would be very interesting, what Dr. Lalit Verma is asking for an extended regimen for even aflibercept. At this point of time, 2 milligrams is the approved dose, and that itself is having a sawtooth. That is, every 8 weeks you are tending to get some fluid, but there is an 8 milligram aflibercept which is awaiting. If that comes, I think between faricimab and also aflibercept 8 milligram or even brolucizumab, people will be having debates on which one to use, based on more probably for safety reasons, and also personalized treatments where you may have to see which one is, even you can, till now nobody is talking about treat and extend for brolucizumab or even faricimab. Also the protocol was like treatment beyond 16 weeks. What will happen with that is a big question.
What is the difference between PTI and PRN injection? Personalized treatment
So in PRN,
every month?
no. PRN is not monthly. Monthly is monthly. PRN is when the fluid comes, you inject.
PTI?
PTI is capped. So in PTI, you can extend the patient from 8 to 12 to 16. But whoever is in the 8 weekly arm gets injection irrespective of fluid. Whoever is in the 12-week arm gets an injection irrespective of fluid. And 16-week arm
You can't
gets
extend.
But you may have to bring down the 16 to 12 if the fluid coming.
More or less like
Treat and
More or
extend,
like-
but you
Yeah.
can't extend.
So-
Treat and extend.
So, sir, PTI is personalized treatment interval, and PRN is pro-renata, which is as needed. So as Dr. Narayanan explained, that's the difference. But coming back to this, so
You know, I
the
was asking about
question,
the drying effect. Drying effect, you see, there's no doubt brolucimab has a very good drying effect. Any comparison between these two brolucimab drying effect? See, one he said was it's a dual action. That's very nice, very appealing, very attractive. Second is about the drying effect, and third is about the durability. So those three things has to be addressed to, you know, I hope the whatever this data is available is hopefully reproducible in real life scenario also.
yeah, actually that is what is a interesting aspect of this molecule, that the real world data seems to be even better than what was seen in the randomized controlled clinical trials. And that could be also because in a trial, what happens is you lump together all patients in one cohort and the other, and the same treatment for all of them in that cohort and this cohort. In your practice, obviously, each patient is different. But coming back to this drying effect, so as you rightly said, one of the hallmarks is the drying effect. We don't have a specific head-to-head study against brolucizumab, but if you look at only the drying effect in the studies with aflibercept, what we've seen is there's a biomarker called macular leakage area, or MLA. That is one area where definitely a difference was seen. And what Dr. Narayanan mentioned in terms of the sawtooth appearance, which is the fluctuation in that central subfield thickness, that has been seen with both faricimab and aflibercept. Now, I'm just wondering, like if you look at 24-hour BP or 24-hour glycemic control, there we say a sawtooth is not really good because it is associated with more target organ damage. In the eye, apparently, it is an clinically insignificant epiphenomenon. So we have yet to see in terms of that CST fluctuation. As long as it remains within a range, I think it's fine. There's
No,
no.
even in AMD, studies have shown that variability of fluid has worse impact than a constant continuous fluid. So it does impact the outcome based on subgroup analysis of various, including CAT trial. But overall, I would say, just to repeat, you mentioned what is PRN versus PTI. PRN is reactive, PTI is still proactive regimen,
This
like
is
treat and extend.
capped treat and extend VTI.
Yeah.
That is the word. Yeah.
Yes, capped PRN, that is
Capped,
still proactive. But Dr. Durrani, if
And these four are monthly injections. These first initial 4 injections are monthly,
Yeah.
yes, 4 weekly.
4 weekly.
Yeah. So, what was the difference in the safety profile, especially inflammation? That's something the audience would like to.
Yeah. So what I was studying about this, angiopoietin and Tie2 pathway, because actually I didn't know what it was. So I went to the basic sciences and I studied about it. Now, so yeah, so this tyrosine kinase, this receptor which is there on the cell, So when you have this ANG2, it is pro-inflammatory. So anything that blocks ANG2 is going to itself have anti-inflammatory effects. So that is one more safety profile we have in this drug, where the inflammation which we see with the other anti-VEGF drugs is neutralized maybe by the excessive blockage of ANG2, which is a pro-inflammatory effect. So I think that's what is making the safety profile of this drug better. Because I didn't know this angiopoietin
Will
and
steroid block ANG2?
Sorry, sir?
Will steroid also block ANG2?
It will inhibit how a steroid basically works is by mechanism of action, it will inhibit at the genetic level in the nucleus of the cell, the production. But this is where it binds to angiopoietin 2, and that's how it is anti-inflammatory. Plus, as Dr. Dudani showed, that FC portion is also engineered such that it has a reduced inflammatory potential. So I would not really expect inflammation to be associated with faricimab.
Because this is working on the downstream, that last path, where that it's interacting and causing, like, you can say the RNA change which is happening, that receptor which is binding to Tie2 is what I studied about it, in detail. Yeah.
So,
It's quite
Dr.
impressive.
Viraj, if I can ask you a question on the
Yes, sir.
penetration of faricimab beyond the RP into the choroid, has that been looked at? Because we know brolucizumab having a much higher penetration into the deeper retina and choroid compared to ranibizumab. There have been animal studies. Why I am asking is one is related to AMD. Could there be some differences versus also PCV? You have just started
Yeah.
the trial, the Salvin trial. So, are there any studies on that?
There are some initial kind of studies, and that's why we are looking at even PCV as a subset of ARMD. But when you look at the size, that 149 kilodalton, obviously it won't be as small as the others. So in terms of penetration, it does penetrate, but maybe the smaller would penetrate better that way.
Are there any questions from the audience? Anybody?
What is the cost of this drug in US?
I'm not really aware, but my marketing colleague is here. Arjun, what is the cost in the US of faricimab or Vabysmo? Louder, we can't hear.
You can come to the mic.
There's a mic there.
$2,500. Same as that.
Dr. Dudani is saying
Just about
$2,500.
Yeah.
just above aflibercept. But what Dr. Lalit Verma has asked is the most important question. I am sure the audience will also have. But the point is, in India, it will make a huge difference in terms of the pricing, and unless it's within the price range where if it's just even initial treatment you want. So because we know real world data says that most of the patients or practices there is hardly 3 to 4 injections per year that are given. So if you price it in a way that you are beyond the range for initial treatment and only a reserve for resistant cases, and you already have 3 to 4 injections given off and nobody is going to come back for faricimab. But again, still that's a very, very important consideration. Given the clinical efficacy, the pricing still has to be competitive is what.
Yes, sir.
The reason Raja raised his point was India is a price sensitive market. A lot of people do not have insurance and all this corporate this thing. A lot of people pay from their own pocket, and pricing has to be critical because you see aflibercept and other, they have their some 2+3 or whatever, so many schemes are available. In fact, it's a price war now between biosimilars and aflibercept and so many schemes coming up, and you are on the launching pad.
Yeah. So, sir, we also will, one is the pricing. So, Arjun, even right now, is trying his level best to get global to accept a separate pricing as far as India is concerned, which will obviously not be like the US pricing. Second, we also have access programs. So, depending on, whether the patient
have what program?
access programs.
Yes.
It's all about access. So patient support programs where depending on whether the patient is below the poverty line, whether the patient is reimbursed, and in between, what
No,
exactly
it's
can
not
we
below
do?
below poverty line.
That we'll have to give it free
BPL
also,
patients
yeah.
you will not get any. We are not talking about BPL because that is different.
No, even
Plus,
correct.
Plus approval by CGHS and other.
Yeah, correct. We'll do that. And sir, I just want to respond to your earlier question on the design of these studies. So you're right. Now, these are two studies each. Why? Because US FDA insists on reproducibility. So both these studies, whether in DME or nARMD and now for RVO, they are all similar. So we just want to see, or rather US FDA wants to see reproducibility. So here, durability was not the primary endpoint. So that much let's be clear about. But naturally, you'll also look at durability during the study, and there we did find differences. But at the same time, that was not the primary endpoint. But what we've seen with faricimab, because of its longer half-life, because of the dual action, is you can give it up to even 4 months as an interval. But I'm not saying every patient, because if you see the data, I think 60...
This is where statistics can mislead. No? Question is statistics are always... What I was saying was, I don't know, Dudani may be able to answer better. You were giving, this faricimab at some intervals, but if aflibercept also is similar, then only you can compare.
No, sir, in this design, you have to go by what is
existing.
Approved.
Yeah, I know.
So that's how, but now as Dr. Narayanan said, I think with aflibercept, they've also upped it to 8 mg. Now with 8 mg, what happens is you can obviously inhibit more of the VEGF-A, but angiopoietin 2 doesn't get
that dual pathway is a very attractive thing, very attractive.
I had one more question. In the brolucizumab Hawk and Harrier, unfortunately, PCB was only a subset analysis, and they had only baseline ICG. In Salvin, I'm sure you will be looking at polyp regression as well. Is that right?
Yeah.
For faricimab as a secondary endpoint.
Yeah, because I think in our Southeast Asia, I think IPCB forms a very large subset of AMD, wet AMD patients, I think, So I think we have to treat that separately. Is what I'm
Penetration here, like I'm looking at the size vis-a-vis, like if you look at a ranibizumab versus a
Yeah, the
bevacizumab,
kilodaltons
obviously
is
there is a
brolucizumab is
difference.
really small.
How much is the size?
This is 149 kilodalton.
149. It's similar to
Yeah,
ranibizumab.
correct.
Yeah.
No, ranibizumab is 49.
No, Rani is smaller.
This is
It's the
bevacizumab.
truncated. Yeah, correct.
Brolucizumab is
Correct.
26.
So penetration in any case will be limited. So usage in patients of say type 1 or maybe PCV.
No, PCV, we're doing a study, sir, called Salvine, where we'll actually be looking at these patients because that is something which you see more in Indians, Asians, which perhaps are not.
Japanese,
Yeah.
Very nice. Any other question?
No,
Any
I was
questions
hoping
from the
there are
audience?
more
Yeah.
questions from the audience. And actually, Dr. Lalit Verma, you also had a presentation, or you?
No.
Okay.
I didn't have the presentation.
You can have that question if you want. Sir can ask.
Need to wind up.
The questions which you were to.
The question set was there.
Is there a
Yeah, those questions are there. You can tell them to put it up.
Amit?
there's some
Is Dr. Amit Thavkar here? Those questions which you wanted the panelists to answer?
oh, it's for panelists.
These are questions which Dr. Lalit Verma would have asked the panelists.
Answers also there.
So those voting pads are not.
Yeah, that's why they're given that voting pad for that.
So panelists are here. Audience is voting pad is there. No? Is for the audience or is it for?
Talk upload is there.
Put it on the screen so they can also see. No, we have some time till 2:25, so that's why we thought.
This is the quiz, yeah. Yeah, this one. Lower one. Next, he's only play. This one, yeah. Yeah. Not this one. Wait. You have to project it, no? You can ask the questions. Set of questions are there. The same what we had the doubts. That was Lalit's question.
No, this I already asked. What are the challenges, these latest innovations, and what are we looking for? See, like duration, durability, and dual this thing mechanism of action. These are main attractions
of this.
And I hope we are live up to all these things. And unmet needs in nuclear ARMD is always there. You see, all patients we are looking for increased duration of action so that their visits to the hospital is
Reduced,
minimized.
yeah.
And we keep hoping that each molecule which comes, like brolucizumab came, but there's a fear. There's a fear. And hopefully that if that fear goes away, then this can occupy that space.
True.
Any
Less injection, less cost, and
Less visits, yeah.
and more drying. Everything
More
is these three. More drying, less injection, less cost. India wants that.
Other point was about the additional benefit. You see, if you compare with today, aflibercept is virtually ruling ruling. It's number one drug in the management of DME, at least number one drug. So, what do you think? Where will you place this new molecule?
I think it all depends on the pricing, is what I would say, because the aflibercept pricing which they have done with that patient support program is quite very attractive. So if they price it well, I think this can fill a niche which is missing. In our resistant patients, as I showed you one or two of my cases, I think we all have a subset of patients in both the groups who are not responding somehow, a non-responders type, and diabetics are much more non-responders vis-a-vis. We have seen that, so that can be filled in, that missing link.
Non-responders will not mind regarding cost. It is
True.
Everything will work in others. So it is cost, and cost.
Very
Yeah,
true.
so the question also, yeah.
Also, do you think that better drying, better anatomy is translatable to better vision also?
Yeah, so that's what they showed in that one of the studies, that the CST reduction reflected in the vision improvement also in these groups.
But we
And
keep shouting everywhere, it may not also.
Correct.
You see, we keep,
yeah.
so,
So there was a real life follow-up of this data, like, real life study after the trials, in which they have published that the visual improvement or the wow effect is much more in this subset of group. It was which was a study, I don't know, it was there that,
Truckee.
yeah,
maybe,
vis-a-vis.
maybe more in the naive group rather than in the resistant
Yeah,
group.
and sir, you're right. In the past, there were these studies where the correlation or the congruence between the best corrected visual acuity and the central subfield thickness was not always there. With this molecule, they've actually seen some kind of congruence.
So in general, more the drying, better is the visual gain. That we see from protocol T. Bevacizumab has the least drying effect and the least improvement. Ranibizumab is intermediate. Aflibercept is high. So in general, but in individual cases, you have to go down and see a photoreceptor ellipsoid zone disruption
True.
and drill and other things.
Yeah.
But in general, there's a good correlation.
I think the biggest advantage over the existing will be a durability and better safety profile also.
True.
See, this country is afraid of a 4% figure which comes with the tag of brolucimab. So maybe, this can be overcome with this.
So actually, I showed a slide of side effects in that, and vascular occlusions, and was zero in that. If you saw that, that highlighted that.
No, even with brolucimab, Ajay, there's a difference in Indian experience
Very,
vis-a-vis,
that's what.
yeah.
So Lalit, I wanted to ask you, do you have any thoughts on that? That why is our patients behaving so differently with brolucizumab?
The only explanation I have is apart from those genetic,
Genetic,
I can't, because those are, once we don't understand, we call it AI or genetic or these things.
Correct.
But our aggression is not there in brolucimab. Brolucimab, most of us are not giving every 4 weeks or this.
Yeah.
You see, if you, a smaller molecule, 25 kilodaltons, which, and high molar mass.
True.
If you keep injecting after 4 weeks, then maybe the side effects are more.
I think that's a point.
In India are not giving so aggressive.
True,
I don't know what Raja has to
I
say.
agree in the sense that could be a reason. We are mostly following PRN. We means
Yes.
most
From
practitioners in
beginning,
India,
yeah.
from beginning, we are not giving 3 injections. Usually with brolucizumab, the occlusive vasculitis after the second or third injection,
Yeah.
and we are giving very frequent intervals.
So I think we learned from the Western experience, and we started PRN, is what I'm trying to say. That's what has saved us, maybe. Yeah, true.
So I think with this we conclude this session. Thank you all so much for
Thank
your
you very
kind
much.
attention.
Thank you so much.
Thank you.